Welcome to today's episode. Today we discuss myths, misconceptions, and misinformation about vaccines and vaccine R&D. I am Lillian, your host, and with me is my co-host, Evelyn Gitau and Professor Omu Anzala.
Okay.
We will be discussing everything around why vaccines and vaccine R&D are shrouded in mystery and myths and misinformation. Evelyn, what are some of the general myths and misconceptions, even misinformation that we hear or that you've had in your science life career?
I mean, there's so many things. I'll start with the first one, that as Africans, we do not contribute to the science that comes into play when we develop vaccines, when we think about the background as to why we need vaccines. It's all defined by the West. That's the first misconception. The second one is that we have not made a contribution over the years. So today we have Prof Anzala here. I've known Prof for many, many, many years. I don't want to say how many, but his career has gone across many, many seasons of misconception. Back in the day when HIV-2, and I always mention HIV-2 because my godmother, late, bless her soul, Professor Ngugi, was behind the Majengo project and the prostitutes who were found to not get HIV despite a lot of exposure. That was not a Western finding. That was a local finding by researchers like Prof, who actually came to and understand the biology behind that HIV too. So I'm going to turn to Prof really to introduce himself, because I'm trying to trigger him to say, tell us about yourself. You've spent so many years trying to fight the misconceptions, the barriers, and to build on a wealth of science on the continent.
Yeah, thank you very much for the invitation. And it's interesting. My names are Omu Anzala. I'm a professor of immunology and virology at the University of Nairobi at the KAVI Institute of Clinical Research. Correctly, as you have said, we actually started off with Elizabeth Ngugi at the sex workers clinic just here in Majengo. I think part of the myths or part of the difficulty has been that research was not an African culture. But nonetheless, I think the work that we did in terms of community engagement actually ushered in the understanding that research can be done on the continent, that communities at the lowest level can actually be made to understand what research is all about and what are really the benefits of research. Because although now we still don't have an HIV vaccine, we are still searching for it for the various issues that maybe we'll discuss in another forum. The aspect that all the preventive measures that were required were actually discovered, and quite a number of them were brought into policy and variously into practice. So that was a clear indication that really you can usher in research. And with community confidence, work can actually be done. And policy can be done and practice can actually take place thereafter.
Yeah.
Yes.
I mean, it took a lot of trust to get the sex workers to come out and agree to be part of it. And as I said, I like this Prof Ngugi was my godmother.
Yes.
So I watched this lady come out of, she was a matron, she retired from the hospital, and come out and say, look, there's a lot of community health research that can enable research to be done better.
Yes.
And so when we started, at the time I was working, I started my career at KEMRI. And you remember we used to have a snake as part of our logo at the Kenya Medical Research Institute.
Yeah.
And we had to remove it because we were collecting blood from the communities. And suddenly, of course, these people who have a snake in their logo are collecting blood from the community. I used to work in Kilifi at the time. Understanding what scares the public is really, really important for us to address, to then enhance the work that people like Prof and myself have done over the years to try at the same thing. Malaria vaccine, we finally have one, but that was the research that I started 25 years ago. So I want to hear from you a little bit, Prof, around your journey in, you've started, you mentioned, and I like it, that was over 30 years ago.
Yes.
Where you were talking to communities and community engagement was at the forefront of your work, yet you are a lab scientist. So tell us a little bit about that journey and changing misconceptions and then enabling us to become global.
Yes. Actually, from the bench, okay, to the field. But it came to my realization very, very quickly that really you are sitting on the bench, but the sample has already come from the field. All right? So it is actually from the field to the bench and back to the field. And hence, that critical component of community engagement. Because part of what we used to see, it was not a one-off. You want to see a volunteer month after month for a year or 2 years. So how do you engage this lady or this volunteer for this period of time? You must build confidence. You must tell them that what we are looking for is critical for the greater good. And that's really what kept the community coming. It's not any other thing other than having to explain that if we have an HIV vaccine, it will enhance, it will reduce the mortality, it will reduce the morbidity, if I may use those words, of what you are seeing.
What is mortality and
mortality
morbidity?
is death.
Morbidity.
Mortality is death. And morbidity is just sickness. Okay, recurrent sicknesses that keep taking you back and forth from the hospital. And if you are better off, then you are in a position to do your work without interference. So, and now it has become common knowledge that you cannot do any form of research without community engagement. And it's a community to the lowest level. Before even you talk about policymakers, isn't it? The people you must engage, clinical trials or otherwise, have to be the community themselves, because that's where the knowledge comes from. And these days now we are beginning to use the word citizen data. Citizen data is nothing else other than the information coming from the community. Yes.
So, Prof, as somebody who has been in this field, but also Evelyn, you've been in research for years. What are some of the most common, misconceptions you hear? And this does not only have to apply to, let's say, vaccine, Prof, where you've worked. I mean, HIV vaccines. But generally vaccines, they could be vaccines that have already been tested, proven to be efficacious. They've already been rolled out in communities. What are those issues that people struggle with? And not just in Kenya, but let's say continentally across Africa.
You want to go first?
I mean, I can go first then and talk about the issues about where the vaccine is coming from. We never questioned where until COVID. I don't think we are, because we are actually in Kenya and many African countries, we're well vaccinated when it comes to children vaccines. Our coverage is sometimes even higher than some of the states in the US because of knowledge or lack of. I don't know. It's never clear to me whether it's because now we have a lot more knowledge or exposure to information, not knowledge. Let me call it information, because that's where the misinformation comes in. So we never questioned it because we knew that it was good for us and we saw the effects. And I'll come back to early days of childhood vaccination. Mortality, under 5 mortality was very high. All we needed to do was increase uptake of, the measles, the polio vaccine, and we saw a change. When I started working, tetanus was still a problem. That was my first research project, was to see how we can ensure we don't have any tetanus in Kenya. Now, at the time, if you had even 2 incidences of tetanus, we called it, that was an outbreak. We had to deal with it.
2 incidents?
Yeah.
Okay.
Now, if you have ever seen a child with tetanus, trust me, you will work. That was my first, when I came back to Kenya, my first exposure in the hospital ward in Kilifi was a child almost breaking of tetanus. I mean, if you see a child, it is visible. But we have a very effective tetanus vaccine. Then comes along myth, misconception, and misinformation that this tetanus vaccine is introducing what? introducing what was it? No, what's the word? That it's not. We were
Guinea pigs
of a vaccine that doesn't work. That we were for the women who are being vaccinated, we wanted to make them sterile because of
control birth issues, infertility.
And this was being sold by people who had never seen tetanus and the impact. Yet, many of them, all their wives and women were being given that tetanus vaccines for a long time. That's why many of us did not die at childbirth, because our mothers had been vaccinated and we did not have to deal with tetanus, right? So I've come back with basic vaccines that have been, misinformation about tetanus continues up until today. We struggled to recruit women in Kilifi. At the time, it was the poorest district in Kenya. Education levels are very low. We were seeing a lot of tetanus. So I tell you, sometimes we need to show these pictures. As I said, if you ever see a child with tetanus, you will be the ones standing with placards on the street saying, no child should have to go through that. Okay? So let me pass on to Prof.
Yes. Actually, the vaccine hesitancy has just taken another level altogether. Issues of reluctance and refusal to have vaccines. And part of it has actually been just media misinformation from unreliable sources. And I think part of the trajectory actually occurred also during COVID, in the sense that within a year or so, we already had one or two effective vaccines against COVID. And then the worry was, how come it was done so quickly? And yet we had been struggling to get a malaria vaccine, to get an HIV vaccine. But you see, but we as scientists never really took time to explain that it is technology that has also advanced. Yes, it is technology that has also advanced. So then there is the confidence with scientists. There's also the confidence with policy, and there's also lack of confidence with the pharmaceuticals. So people started seeing this as, as just big pharma or trying to make money. Then the issue of aspects of safety. All right? Then everybody says, you've done this thing so quickly. Is it safe? All right? Is it safe? So all these aspects have actually now brought a lot of hesitancy, where there is confidence, people refuse, people agree. So even if you add another vaccine, that tendency actually continues. And then there's an avalanche of information out there. If you look for any negative information, it is there. You only need to Google and say, side effect of measles. And then you'll just get all of it coming. So those are really the issues that we need to deal with. The whole aspect of it is that vaccines save lives. All right? That we know. Vaccine saves lives. So how do we then move to the next level to begin now to reduce the whole issue of hesitancy? And then lack of confidence also with government and people in the public sector. Why is this vaccine free? All right? Yes. Yet, nothing is ever free, isn't it? Nothing is ever what? Free. We say free at delivery, but there's been a lot of what? Aspects of logistics and ensuring that this product actually reaches to the end, to the end user. There's a lot of investments actually put in. So all these are things that we actually need to begin to deal with properly and actually explain to communities. And then again, engaging to deal with hesitancy cannot be general. You have to engage each community individually, isn't it? Because their aspect of lack of confidence varies from community to community. What I'll communicate to religious leaders will be slightly different from what I'll communicate to maybe chiefs, okay?
Yeah.
Or people in the public sector, or people in the private sector, or women groups, isn't it? So that information has to be tailor-made to ensure that we are actually addressing each group with their own reason for hesitancy. Yeah, those are the aspects that we should actually be trying to get at.
Completely.
Yeah.
I mean, you've said a couple of things that are of interest to me and have always been very passionate about. I think the first one is in relation to the HPV vaccine. The misconception there has been getting HPV is as a result of sexual immorality.
Yes.
So that's the first misconception. In fact, I had a conversation with someone who was saying, oh, why should we worry about our 15-year-olds? They're not having sex.
Yes.
I said, oh dear. Who told you that? My gynecologist said we don't need to have them vaccinated. So, the numbers show that most of us have been exposed to HPV even before birth because it's just rife in the ecosystem. Okay, so that's the first thing. So the person who is supposed to be educating the health practitioner themselves has misinformation. If a gynecologist can tell a mother of girls that you don't need the HPV vaccine, we have a lot of work, Prof, don't we?
Correct.
So that's the first one. Now, the other thing about HPV is that we know it can and will prevent and the issue that leads to cervical cancer. Cervical cancer is who is it affecting the most?
The women.
The women, right?
Correct.
But then the people who are against it are the church leaders, mainly men. So the shoe, who is it pinching? And they're not the ones getting the right information. So we need to think about, as Prof has said, the right people to attract and the conversations you need to have about the fact that HPV leads to cervical cancer, which is the number 2 cancer killer in most of our countries on the continent. That's the second thing. Now, the other thing about investments that go to research. We keep coming back to the fact that we don't have an HIV vaccine. We now have a malaria vaccine that, for better or worse, it is the first time we can say we have a malaria vaccine. If you look at the investments that were given to researchers towards studying and understanding what would make a good vaccine in HIV and in malaria in the last 30 years, I'm talking about dollar amount. And then you look at the money that was made available for COVID vaccine. It's the same. So now let me ask you something. Money makes the world go round. We know that. We know that. So if you give me 20 bob today and tell me you need to make some tea, 20 shillings to make some tea, and I'm like, I don't have enough for even milk. But then if you come to me and I say, you have guests, here is 5,000 bob. Oh, I will very quickly prepare a feast. So you see the difference, right?
Yeah.
So the acceleration is because the investments that were made were at a much higher level. And this was done because the world was in trouble. The shoe, remember I talked about the shoe. It was pinching everyone.
Everybody.
So everybody was like, let's put all our resources. But when we talk about malaria, HIV, there's a perception that is an African problem. And for Big Pharma, actually, the investments for them don't count because they don't sell as much. Okay.
But do you think that then that is where the problem is or lies? Because, and still, Evelyn, like you said, when Prof, you talk about all these issues that actually contribute to the misinformation, misconceptions, it's a myriad of things. Starting with media. Media is here to stay. We are now bombarded by social media. Young people around the globe are on social media. That's where they find their information. They're not going to find it in books or publications or mainstream media, what we call legacy media. They are going to go on the socials. And what are we doing about it? Why do we stay in our cocoons and not be out there speaking on behalf of the work that we do to demonstrate that actually what we're doing is helping society? I think that's a big also failure on our part.
Okay.
Yes. And then Evelyn, when we talk about COVID, I had a sister whose entire family was hit by COVID. And I told them, go get vaccinated. And she told me, no, Lillian, originally we used to use herbs for these flus and coughs, mango leaves, and you mix them with what. During COVID is where you saw people come up with all these forms of, herbals that they used to wait out the epidemic. And so, I mean, the pandemic. So I'm struggling with two things here, I should say. When you find the advocates of our herbal medicine, and then us in the area of scientific research, how do these two speak to each other? But also, how can we in the industry help them to understand the value that actually science brings to vaccine research and development, dealing with the challenge of social media? Prof, yes, you've been at this 30 years.
I've been at it long enough.
Today we are dealing with the swiping, people on phones swiping. How then do we support people to understand that actually there is much more science that happens before you see a product? I think these are the things I'm grappling with, and I would love to hear from both of you.
Two things, herbal medicine, cultural issues are in the Ministry of Culture. All right? Herbal medicine is hardly ever regulated. All right? Or if it is, there's minimal regulation. It also doesn't doesn't require the rigor that we normally go through when we are doing, the traditional research in terms of discovery science and product development. So there is actually that dichotomy. And I can tell you, I've been at it long enough, we don't speak to each other. All right? We don't speak to each other. When we look at herbal medicine, we always look at from the point of view of evidence. Where is the evidence? And then it's a concoction that is put together, all right? Where you have it's also not very, very clear. But having said that, it's not to say that herbal medicine doesn't work. India now has actually agreed that both will go hand in hand. And even in this country, we keep seeing people going to herbal. When things don't work, is now when they come to conventional aspects of it. All right? Yes. I think the whole issue is that we do things not in a continuous manner, but when we want to introduce something is when we start advocacy.
Exactly.
Yes.
Yeah.
All right? When there's nothing, we keep quiet. For example, we've just introduced the conjugated typhoid vaccine. All right? We want to start giving it, I think, at 9 months or so. But ideally, if you asked me, we should have started this story 2 years ago. Just engaging with communities at all levels. Why is typhoid vaccine important? Because somebody would ask, but we don't see typhoid. But the issue is that we are shifting the paradigm from crisis management to risk management.
Exactly.
Yes. You don't need to see typhoid to start saying that there is a problem. We don't want to see typhoid.
So we better start by preventing.
Exactly.
Rather than waiting for people to get sick.
And that then means that we are educating even healthcare workers to move away from the paradigm that we have to have a burden, isn't it?
For us to create the need.
To create the need. But we now come from the point of view of risk. Then risk means that we want to have a vaccine, all right, and start giving it out. But then also the risk means that we want to have a clean environment. We want to encourage wash, isn't it?
Yes.
And water and everything else. So that a vaccine is just one of
the mechanisms of prevention.
And that's hence the whole issue that this communication cannot only be done when we want to do something. This communication must be continuous. Even actually being able to tell people, why are we interested in typhoid vaccine? Because somebody asked me when we were introducing it, but Prof Anzala, we have treatment. Yes. But what is the cost of managing as opposed to the cost of preventing?
Yeah.
And that is now the discussion we'll have at policy level, at practice level, and that's now communicating to the healthcare professionals, because they are the ones who are likely to ask those kind of questions. Yes.
I like where this is going, because for me that whole issue of mitigating against the risk is where we should focus. Unfortunately, our insurance products, whether private or public, have all been developed as something that manages the disease. Prof, we were talking about it earlier.
Exactly.
The difference between encouraging a healthy community rather than managing the disease that affects the communities. So we need to think very carefully how we communicate the return on investment for research. And I think one of the things is to say, look, if we were to prevent all these diseases that we see, that can be managed, that can be effectively managed with water and sanitation, a vaccine here and there, rather than waiting for people to get sick, we would actually look at the long-term benefits and avoid the investments we make in healthcare, or the lack of, a big burden of why people are dying is because we cannot afford to take care of the sick.
Yes.
But we shouldn't have to worry about the sick. We've now moved on, effectively because of childhood vaccines, we've been able to increase our life expectancy beyond, our under 5 mortality was slashed. In the last 10 years, we see a very big difference, although a lot of gains are going to be reversed if we don't think about malaria and climate change and things like that. That's the first one. The second one, I think, is the issue around the fact that adult vaccines have very poor uptake. So when we started working, and I'm sure Prof was the same, we were the first recipients of the hepatitis B vaccine because we were healthcare workers. We were working in healthcare. Do you know, I was quite surprised the other day when, people, of course, are getting cancer as a result of chronic hepatitis, and that's a big problem we have. I was quite surprised to realize that most of our age mates, people in their 50s, the vaccine is now over 30 years old.
Right, yeah.
But most people, our age mates, have not received the vaccine. So that tells me that we stopped at healthcare workers. We continue, we are fully vaccinated. I'm sure Prof is fully vaccinated, and anyone who has worked in research has had to have the hepatitis B vaccine.
Yeah.
So we took the risk then for the population. Now, 30 years later, we know the side effects that people were worried about don't exist. Do you know one of the biggest cancers we're dealing with in Africa that we shouldn't have to deal with is liver cancer? And we're dealing with a lot of liver cancer because of chronic hepatitis. Chronic hepatitis that has 3 hepatitis A, hepatitis. We have vaccines for all of them, isn't it?
Not all of them.
Yeah.
Yeah, but at least for hepatitis B,
yes,
effective vaccine.
Effective vaccine.
Hepatitis A, maybe not a major problem, but another effective vaccine.
Exactly. So these are things we now we're dealing with. Everyone is like, why has cancer gone up? Yeah, because we've cured we know how to cure the infections that cause the cancers. But in that moment when you've been exposed to that infection, you're actually starting to build precancerous cells. My biology has gone wrong, but it's been a while since I've been on the bench reading. But Prof can tell you, the minute inflammation is exposed to your system, you're going to get cancer later on.
Yeah.
And a lot of inflammation is caused by infections that we could prevent if we were vaccinated.
Exactly. I think just to add on, there are 2 aspects. We are now beginning to talk about mind the gap. And mind the gap is that vaccines have been associated with pediatrics.
Yes.
Isn't it? But now minding that gap is that we are now moving to vaccines for adolescents, vaccines for adults, vaccines for the elderly, or if I may call them so, or maybe let me use a better word, seniors. Okay.
Now that you're getting closer.
Yeah, now that I'm getting closer. Vaccines for seniors.
Yes.
And then vaccines for special groups. Yes, because the new antigens are coming in, and special groups also include pregnant women. And the issue we had with COVID and pregnancy. So there are 2 aspects here, Evelyn, to add on to this, is the issue of lifespan and health span.
Yeah.
All right? Lifespan is longevity.
Yes.
All right? But you want to ensure that coupled with the lifespan, you have a health span. And health span is a quality of life. So you don't want to be 60 and you are riddled with cirrhosis, isn't it?
Exactly.
You are sick and in and out.
Yeah.
So the aspect of vaccines and all the things to do with prevention is to ensure that as we live longer disease-free.
Yes.
Because people miss out when they just talk of longevity and lifespan, forgetting about health span. And these things must actually go in tandem. Yes,
Yeah.
exactly.
So it's quite interesting, because I'm seated here and I'm asking myself, health workers, people who are working in health facilities, everybody, irrespective of whether you're a medical doctor, a lab technician, if you're in a health facility, and people out there will tell us, when you enter that health facility, everybody is doctor. In Uganda, we call them musau, So if you can imagine, if you walked into a health facility, your assumption is that people in there, or if you go and meet a doctor behind the desk, they need to know everything about anything. And when they ask them about HPV and they are told you don't need it, this person will take this as gospel truth. I actually spoke to a doctor.
Yeah.
They said it's not required. Now, that then brings in a very large or very big problem. The health workers, including medical doctors, not everybody is a specialist in a particular field.
Yeah.
So we therefore need to help people understand that when you get into a health facility, you're looking for vaccinations or vaccine-related information. Not everybody will have that information on their fingertips.
Yeah.
So having said that, how do then we in the scientific community begin to address this issue? How can we navigate the misinformation, the myths, the misconceptions?
You see, what you have asked is something that we've been thinking about, a number of us at the medical school, University of Nairobi. But and thinking from the point of view is that you have all this information, but it's not being translated.
Yeah.
And the translation is only not at community level.
Yeah.
The translation should also involve healthcare professionals. We make assumptions that doctors, nurses, or healthcare professionals know these things. That may not necessarily be true. So we formed a small outfit called the Wellness Institute Trust. And the whole purpose of the Wellness Institute Trust is translation. And one thing we started with is discussing the issues of vaccines. What vaccines are available, isn't it? What is the safety profile? Who are they going to be given to? And the whole issue of what I said about minding the gap, isn't it? Looking at what is for children, what is for adolescents. And we are providing this information to start with healthcare workers. And I think that is something that we must continue. So that if a healthcare worker comes and if a community or any person comes and asks any healthcare worker, have you heard about HPV? Then the person will say, oh yes, I know about it. Because we make assumption that healthcare workers know.
They know.
Yeah.
So translation, even to the healthcare workers themselves. For example, now, last week, the UK government introduced a gonorrhea vaccine. Isn't it?
Imagine.
Yes, it's coming. We should start having that conversation because you know the interpretation.
Yeah.
You can imagine that.
And people who not take it because they don't be perceived
exactly
as people who actually live a normal life.
Exactly. Okay.
Our audience should not wonder what normal life is. We'll get to those conversations.
So the whole issue is that we must be at par with what is happening.
Yeah.
I think part of the reason why HPV vaccine also got
the bad press
was that the side effects that were being seen were more of anxiety, and was also because of the age group. Girls of 11, 12 perceiving pain, then they become very anxious. Some of them even collapse. That is what gave the HPV vaccine a bad press. But we just need to go back and re-engage, okay? And not just communities, the entire process, from the policymakers down to healthcare workers, to the individuals there, themselves. And it needs to be done now because we have HPV vaccines that are going.
We've thrown out. They've actually expired.
Exactly.
So we're actually throwing out vaccines that were supposed to be given for free because we were not able. The uptake for what we had in the stores was 13%. So now we're just throwing them out, saying they've expired. Yet we know that would have prevented all these girls we have. They don't have to deal with the worry of cervical cancer if they were vaccinated, or at least some of the cervical cancer that we see. So these are issues, and in fact, I love the mind the gap conversation because as we live longer, infectious disease is one of them. This is where we talk about vaccines, but we are now in an era where we know the burden of non-communicable diseases are is a crisis that is coming. And one of the things we've been talking about is our primary healthcare workers are not ready. They don't even ask questions. You ask, in Kiswahili, you'll say, do you have a fever? Okay, yes, no. Are you feeling pain? Yes. Then we say, you know what? All I can give you empirical treatment. My research was all about trying to reduce empirical treatment.
Exactly.
So you give your antimicrobial, your antibiotic, you give your antimalarial, and some Panadol, and you send them away. All right. But we know for a fact that now people are going in there. Diabetes is a big problem. Early onset, at 20, 30, we are seeing type 2 diabetes when we were seeing it later. We have not even at 20, at 14, 15, young people are presenting with type 2 diabetes. We are seeing a lot more issues around obesity, malnutrition across the spectrum, from undernutrition to overnutrition as a big problem. But if you go and ask the clinical officer who was trained at the medical technical college, whether they actually had the right questions to ask when they are screening patients, very few of them will ask the right questions for non-communicable diseases. So coming back to minding the gap, is we need to change curriculum.
Exactly.
How we teach healthcare workers is a big part of the problem.
And the whole issue of just packaging prevention. That vaccine is just one of the many things. So that as we go in, and this is how we're actually going to see hesitancy decline, that we are not just going in talking about vaccines alone. As you have said, Evelyn, obesity. We are going in and also talking about nutrition, isn't it?
Yeah.
We are also going in and talking about exercise, so that we are approaching, health and healthy living in a very holistic manner. Vaccine just being one of the
interventions.
because then people see like vaccine is an end. No, it is actually a continuum of all this preventive aspect. And this is actually the aspect of saying the Wellness Institute. This is exactly what we want to do. By the time you hit 60, we are saying, do you need a diphtheria vaccine? Do you need a pertussis vaccine? Because these are vaccines we are given in childhood. You've been around.
Suddenly you're living longer than what was expected.
Exactly. Yeah, so this is actually the discussion coupled with the exercise and nutrition and all these things. And I think if we did that approach, then people actually begin to see that it's not just vaccine alone, but vaccine in a continuum of health. That is the approach.
So As we wind up, I think I would like a take home. I hear you, Prof, talk about the Wellness Institute. And I think this is a good move that we need to start investing in more than just one intervention. And in just your take home, one, what would you like to tell our audience discussing this topic? And please remember, we are not just going to have this conversation once. We're going to come back again. We'll bring Prof again. We'll have other guests to really dig deep into this conversation. So we will welcome questions from you. But Prof, tell us, what exactly would you like our audience to take home from this conversation?
I think from this conversation, what I'd like the audience to take from this conversation is that our conversation involves individuals taking their own health seriously and coming from the point of view of healthy lifestyle rather than waiting to be sick. And as we go on and discuss more, the packages we want to be able to introduce is packages that involve holistic approach to prevention of disease. The longer you live, you want to live a healthy what? A healthy life. Rather than just saying that life expectancy has gone up. Yeah. And yet you are riddled with what?
With disease. Pain and disease.
And actually disease. So that is a take-home message. And I hope that as we move further, we shall go beyond discussion and actually begin put these programs into practice, so that we have fora to engage the various communities, fora to engage policy, for practice, healthcare workers, religious leaders, teachers. And teachers, primary and secondary school, have the largest constituency. Yes, we want them to be able to understand that. Part of the whole issue, we discovered that teachers were not even aware of the availability of HPV vaccines. And yet they have that constituency of 9 to 13 years. Those are the issues that I want to actually put together and see that we can begin to communicate that to the audience as we go further. Yes.
Yeah.
Evelyn?
I think for me really is to talk about the issue about how and why we should trust research, right? Because I think we continue to justify why we exist as researchers, why research is a tool that will, speak to the things that Prof has talked about, the vaccines that are being made, the communities that are being engaged. We have research and evidence. We generate evidence across all this. We may not be packaging it right so that communities can demand their policymakers to make the change. So if we're going to fill that gap that Prof brought about, we need to keep sharing the evidence and packaging it in the right way, especially to those whose shoe it is pinching the most. The communities that need to have the evidence to demand their governments to put in more investments in the prevention, not the cure. We need to learn how to talk to them about the science. And that is the way we will build trust. That is the only way we will get our politicians, because remember, we've been taught that it's not evidence to policy, it's evidence to politics. Politicians will listen to the community. If the community are saying, I need to be better, to be healthier. I don't need you to come to give me that, our financing mechanism of fundraising, where we fundraise for treatment. But if you ask for fundraising to make sure that people are vaccinated, it's very hard. If you ask for fundraising for that gym that is at community level, the open spaces, I love going to Dakar.
Yes.
Because they have exercise machines on the beach for anyone to work.
Exactly.
That's a government who thought about the fact that exercise is a good thing and it should be available to everyone. So why aren't we doing that in all the communities that we exist in? For me, that is the thing. We as researchers maybe need to jump the gap and continue packaging so that the community can do our job for us and advocate for the things that we keep saying we have evidence for in research.
So we have so much to talk about. And this is just a tip of the iceberg. Discussing vaccine research and development is a very, very long discussion that we can't, sum up in just a few minutes that we've sat here with you today. But we assure you, if you share your questions in the comments, we will definitely be back, and we'll be inviting Prof Anzala back, and we will delve deeper into these conversations and how even within us as the science community, we can make this a much more informative, opportunity for all our listeners and our viewers to understand more what happens in the science world around this work. Until next time, stay well.